invite Dr. Venkat Raman to speak on non-invasive cardiac output monitoring.
Thank you and good morning. What a glad morning today. I was thinking after yesterday's night blast, I will see very few delegates, but I'm glad that we have some audience, some delegates to interact and participate. I thank Dr. Pradeep and JIX teams to give me this opportunity, and it was an amazing event in a blast of conferences in the last couple of months or so. In fact, in the morning, from both Dr. Sumitre's and the CVP interaction made my job easy. See, first question is, many of us may not be using non-invasive cardiac output monitoring in our day-to practice in our intensive care unit. But first question is, we need cardiac output monitoring. We all agree that. Why do we need cardiac output monitoring? The last two talks emphasize that we depend on the stroke volume, we depend on the cardiac output to define whether my patient is fluid responsive or not. Now, the second component came, the gold standard to measure cardiac output is a PA cath. And we're saying the PA cath may be gold standard, but it's too invasive. Because it's too invasive, the complications, the adversities with that may override the use of it and making the patient's outcome better. Now we came back to the other two, maybe partially or maybe half invasive or a partially invasive ones. And we are now finding it struggling there, whether they are accurate or not, and we are trying to calibrate, not to calibrate in all of them. So, probably in this context, my discussion of non-invasive cardiac output monitoring, can it be a way forward? Yes, we do all understand that it's in an evolving stage, but taking it forward, can it be a way forward? So, in the next 15 minutes, probably I will not be able to cover the whole spectrum of it, but I'll try to emphasize on the different modalities and the principles used to use the non-invasive cardiac output monitoring. The two bioimpedance and bioreactance, the difference when a low amplitude, high frequency current is passed through is one way. We use one of the indicator carbon dioxide like what we use dye or a thermodilation in a saline and see whether we can measure the cardiac output. We use a pulse wave transit time, the difference between R to a plethysmographic wave, and can we derive it? We use a Doppler in a suprasternal notch and see whether ultrasound guided cardiac output monitor by a Doppler can. We will also see the photoelectric plethysmography and also radial artery ablation tonometer. These are the different modalities which I will run through. My basis of the talk will be, what is the principles used? What is the correlation of these different modalities to the standard, which we say either a PA cath or an invasive modalities, either a PICO or LIDCO, and what are my limitations, and where are we, can we still use in intensive care unit? So bioimpedance and bioreactance are nothing but electric resistance or an impedance difference is seen when a high frequency, low amplitude current has been gone through the different leads which has been kept on the thoracic inlet and outlet. And we see the difference in the impedance, or we see the difference in phases. You can make out the difference in phases. When we see a difference in amplitude by an bioimpedance, we consider it as a bioimpedance related, and when the noise and the other components of electrical disturbance was when counted, and we look at the difference in the phases, we talk about a bioreactance. It looks very simple and easy way, but during this phenomenon, what we see is the whole of the volume in the thoracic cavity in the form of the blood or the tissues remain the constant. The only thing which varies is the blood flow in the aorta, and that will be picked up by the difference in the impedance or the difference in reactance, and that will correlate the output. Initially, there was a lot of controversies related to a cylindrical model, but later on, it was again considered as a conical model with little modifications. This is how it looks in a demo graph, that the leads will be connected and you see the cardiac output and stroke volume index in a monitor. This is the calculation where you actually see a ventricular ejection time and then you see the change in impedance or a change in reactance, and you calculate the stroke volume. It looks very easy and simple, but when it comes to the correlations and it's a different, maybe the interference with the electrical movements and the sternal wires, arrhythmias, and during a critically ill patient, it has not been shown to be good. It may be having some role in a pericardiac surgery or a post-cardiac surgery, but not in a critically ill patient. Its correlation has not been great in a critically ill patient with a lot of boogie, edematous patients. Then again, another interesting part, a partial carbon dioxide rebreathing circuit has been used. See, we have been using a fixed principle to use either a dye, either a saline as an indicator to evaluate the cardiac output. So there is a thought process came, why can't we use a carbon dioxide by using a rebreathing circuit? You can see a rebreathing circuit which has been added to a normal ventilator circuit with a valve, which is a rebreathing valve, and you have a CO2 sensors with a mainstream capnography. And the patient has been connected to this, and this is how the NICO machine looks like. So what do? They actually take 3-minute cycles. In initial first minute, the patient breathes normally through the normal ventilatory circuit, and you get a exhaled CO2, which is captured in the rebreathing volume. And then you will have a EtCO2, because the exhaled CO2 or the product, the CO2 production will be monitored or measured. Then a rebreathing circuit is connected for another 50 seconds. And what will happen if there is a rebreathing circuit? Obviously, there will be no carbon dioxide produced and exhaled outside, and it gets into a recirculation or a recycling in the same circuit. And what happens by that is your carbon dioxide production will drop down, but your EtCO2 will jump up. And then they again will take out the valve, and they see again it gets to baseline. So this is how it looks like. So the carbon dioxide reserve in exhalation will increase in the normal circuit, and when you open the rebreathing valve and it goes to a recirculation, then the CO2, PtCO2 goes up, carbon dioxide production goes down, and these are the different calculations which are used, like what we use in a fixed principle, like carbon dioxide production by the gap. One side you see a normal one was calculated, the other side it was a rebreathing one was calculated, and this is how actually the difference in carbon dioxide production by the arterial carbon dioxide, which has been reflection of EtCO2 into a multiplication factor of S, they display cardiac output, and this is one way which can be done. But again, it has gone through a lot of limitation. A small variation in CO2 can lead to a significant difference in cardiac output measurement, and the lung parameters, atelectatic lung, ventilator, and ARDS lungs, and sick patients in the ICU, this can be really a leak somewhere can also be a complexity here. And then when there was a correlation with a critically ill patient, it has a poor correlation, even though it has some correlation in a surgical patient. And as I said, cardiac output intraoperatively has a good correlation, but when it comes to the critically ill patient, it has a very few. The other way we do is a pulse wave transit time. So what is a pulse wave transit time from a R wave? If you see the maximum pleth and you see the time, that is the transit time between an R wave to a pleth getting into the peripheral pulses. And using this formula, they calculate the cardiac output or a stroke volume and multiply that to a heart rate and get your cardiac output. Ultrasonic methods, this being our common transthoracic method which we use in most of our setups, but this is an ultrasonic cardiac output monitoring method where the Doppler has been used in a suprasternal notch to see the arch of aorta being a tube, and they try to find out the velocity time integral into the cross-sectional area of the aorta. The cross-sectional area of the aorta is generally measured during the transthoracic echo. Just a aortic outlet, and then we multiply it by velocity time integral, which is we calculate each time. But here in this machine, the cross-sectional area of the aorta will be calculated by the demographic variables and is a constant. And the moment you put a probe in suprasternal notch, it will give you throughout the calculation and give you the cardiac output in this way. Again, as it looks simple, it will have its own limitation. Using this in an ICU setting with a probe constantly placing there will not be easy. and pre-calculation of aortic valve area with age and weight will be its limitation, and probably some of these patients' echogenicity will have a difficulty when they are undergone a surgery or something. So again, correlation has some correlation. The photoelectric plethysmography. Again, you see in this image, there is a cuff in your middle digit, which actually increases the pressure to occlude your both digital arteries, and you have a light source and a light detector and an inflatable bladder. So it looks like something like this. In a normal time, the pleth wave will be something like this. You can see the down plethysmographic wave, and with a normal cuff pressure, that is zero, without any cuff pressure. But if you use a cuff pressure, which is probably close to the pressure in that artery, and you wanted to have a similar blood flow, the blood flow remains the constant, but the pulsatility goes out. And this pressure, which is required to take out the pulsatility of the blood, has been reflected in the top as a non-invasive arterial tracing. So if you see, once the pulsatility goes out, and that is reflected as a arterial tracing, and from here they calculated the cardiac output. And again, the correlation remained to be a challenge. The last one, the radial artery applanation tonometry, where a transducer has been placed on the radial artery, and from there, the transducer picks up the radial artery wall tension, and you have to be very accurate that the transducer is exactly on the radial artery, and from there you can actually track a non-invasive arterial tracing on this. So, as we said, I just actually took you through the principles of and limitations what we are seeing in a non-invasive cardiac output monitoring. If you see the accuracy and a gold standard from a thoracic whole body impedance and reactance is probably the least of a specific to a PA catheter or a Swan gas catheter, which may be gold standard and more accurate. But we have limitations of using a PA catheter because it is invasive. And we have a limitation of using bioimpedance and bioreactance, which is less sensitive and less specific. So in between, the other non-invasive, transthoracic Doppler or a non-invasive pulse pressure analysis or uncalibrated pulse pressure analysis or a calibrated one comes in the intermediate way. Probably my take home will be the cardiac output monitoring is required for acute prediction of fluid challenge. You do whatever way you want. Either a pulse pressure variation or a stroke volume variation is the need to give you accuracy of your fluid challenge. PSC may be a gold standard, but it is out of our ICUs. I hardly see in the last 15-20 years. If I am not a cardiothoracic anesthetist, I will be frequently using in a complex cases, but not in a regular medical intensive care unit. Non-invasive cardiac output monitorings are evolving over a time. Probably the Doppler ones or ultrasonic cardiac output monitorings, which are been evolving with a different principle and technique, may give us a clue. But we still have lacking a strong evidence of correlating with the gold standards, correlating with the invasive ones are still lacking. But the question is, why are we comparing with the invasive ones? Do you have a gold standard to compare in non-invasive? We don't have any gold standard in non-invasive way. Can be used in a stable perioperative setups? Probably yes. Can be used in an emergency setup? Probably yes, to get an initial clue of cardiac output and a status of volume. Can be used in an ICU patient where you just wanted to evaluate a shock or wanted to give a volume challenge, but role in critically ill patient is still evolving. Thank you. I belongs to Hyderabad, and I comes from this hospital which we recently inaugurated. It is a 2,000 bedded with a 500 beds ICU. We are proud to be a part of this. So I just thought, thank you for this patient listening, and thank you JIX team for this opportunity. Thank you.
Thank you very much, Dr. Venkat Raman, for that wonderful lecture. Basically, physics is not my forte, but still it was quite enchanting. We will have the discussion at the end.